Hi, and welcome to episode 25 of the Unpacking Weight Science podcast called Weight Loss is Not a Fertility Time Machine. I'm your host, Fiona Willer, weight-neutral professional development dietitian, academic and size acceptance advocate. Let me apologise up front for my cold today. I sound better today than I did yesterday, but I can't leave recording any longer, so here we are. So our learning goals today are to recognise the key messages provided to the public about attempting pregnancy while larger-bodied, appreciate the recent evidence regarding body weight, intentional weight loss and conception, including unassisted and assisted reproductive services, and identify key lines of discussion and resources for advocacy. As I start, I want to make it clear that this episode is not going to be a life hacks for falling pregnant when fat episode. Others do that far better than me. I'm going to lay out some stats and highlight BMI-based BS claims about weight loss and fertility in men and women, but I don't want to give you the impression that this episode has the holy grail of pregnancy tips. Trying to fall pregnant, stay pregnant, and deliver an actual human when that's all you desperately want are hugely life-consuming and can be deeply traumatizing in themselves. So I just want to say that my heart goes out to you if that's you right now, and I hope some of the material presented here can help you with advocating for the effective healthcare that you deserve. So firstly, and not to rub salt into the wound, but to highlight how we get distracted by anti-fat messages, larger-bodied people as a group are quite fertile. Within a year of stopping contraception, 66.4% of people with a BMI of more than 30 will have conceived, compared with 81.4% of people with a BMI between 18.5 and 25. Within another year, the success rates are higher again for both categories. So the difference really isn't that big. From a paper by Norman and Moll from 2018, provided there is sufficient time, overweight ovulatory women probably have the same chance of spontaneous pregnancy in their lifetime as other women who are of normal weight, indicating that while the chance per cycle may be reduced, over time this is compensated for by a cumulative pregnancy rate that approaches normal pregnancy desires. So keep this stat in mind when we get to talking about the reasons behind the reluctance for assisted reproductive technology services to deny services to larger-bodied people. When larger-bodied people fall pregnant naturally, obstetrics and delivery services simply have to deal with it. Unfortunately, that can mean sending people to larger hospitals, sometimes quite far from home, where they should have better services. It's one of those things where all labour and delivery hospitals should have the appropriate equipment and well-trained and experienced professionals to support the population they serve, but at the end of the day, what you don't want is someone who doesn't know what they're doing trying to deliver your baby. So travelling to get proper care is aggravating but absolutely rational at the moment. It's the service distribution that's the problem. More people with a higher BMI have issues with regular ovulation and thus periods, and no matter what your weight is, you won't know if your periods are irregular if you're on birth control. The pill induces a period every 4 weeks, if you let it, and other longer-lasting forms like Depo-Provera, Mirena and other IUDs may suppress periods altogether or artificially lengthen the time between periods. So if your cycles are long, that gives you fewer chances to become pregnant in a year. Normal cycles vary considerably too. The exactly 28-day cycle myth just won't die. So for people who are having issues with ovulation, the literature documents that larger-bodied people tend to need more of the drugs to stimulate ovulation. How this is surprising, I don't know. Have fewer successful ovulations, and if doing IVF, have fewer eggs for retrieval. At these issues, I can't help but wonder if proper experiments to determine dosage based on insulin sensitivity are being done. And in terms of egg retrieval from larger bodies, the world needs better techniques, not more moaning about how hard it is. Anyone who's heard me speak knows that I have little sympathy for healthcare providers who place the blame in their lack of skills or appropriate equipment on the bodies of the people they're allegedly caring for. Despite the majority of larger-bodied people being fertile, reading the public-facing materials on government health websites gives people the impression that people with larger bodies should delay attempting to become pregnant until they've lost weight. For example, this from the Raising Children Network in Australia, a government website. If you're overweight and want to get pregnant, healthy weight can improve your chances of getting pregnant. The best thing you can do is lose some weight before you start trying to get pregnant. If it's too hard for you to achieve a healthy weight, even a small weight loss can help a lot. If you can lose just 5 to 10% of your body weight now, you'll start pregnancy much healthier. For example, you'll have less sugar and cholesterol in your blood and lower blood pressure. Now, remember, we know that the less sugar and cholesterol in your blood and lower blood pressure is a result of what you're doing to lose weight, as well as not consuming enough calories to sustain your body. So it's not actually a flag of being healthier. It's a short-term biohack to mimic what we consider healthier in someone who's in a steady state homeostasis. Plus, what a lovely and completely incorrect assumption that everyone with a larger body has high blood pressure, high cholesterol, and high blood sugar. Now, from the Mayo Clinic in the US, what steps can I take to promote a healthy pregnancy? You can limit the impact of obesity on your pregnancy and help ensure your health and your baby's health. For example, schedule a preconception appointment. If you're obese and you're considering getting pregnant, talk to your healthcare provider. He or she might recommend a daily prenatal vitamin and refer you to other healthcare providers, such as a registered dietitian or an obesity specialist who can help you reach a healthy weight before pregnancy. Again, that message is wait! Lose weight first. And this from the National Health Service in the UK. Your weight before you get pregnant. If you're overweight, the best way to protect your health and your baby's well-being is to lose weight before you become pregnant. By reaching a healthy weight, you increase your chances of conceiving naturally and reduce your risk of the problems associated with being overweight in pregnancy. So the advice to the public is pretty consistent. If you're planning a pregnancy and have a uterus and a higher body weight, you should try to lose weight beforehand. Or at least the NHS materials included, if you get pregnant before losing weight, try not to worry. Most women who are overweight have a straightforward pregnancy and birth and have healthy babies. However, being overweight does increase the risk of complications for both you and your baby. So what kind of evidence is this built on? And where do the humans who are providing the sperm for this pregnancy sit? To unpack this stuff, it's necessary to have a look at the reasons that scientists think that a higher BMI affects fertility, as in, what do they reckon is actually doing what to the egg, sperm, or chance of conception? And secondly, we need to look at what kind of evidence the weight loss recommendations come from. Do they come from experimental trials where larger-bodied people have delayed their pregnancy attempts in order to lose weight first and compared their pregnancy rate with people who just get busy straight away? Or is it the usual sleight of hand where population stats about higher and lower prevalence of issues are used to try to make the case that effortfully changing your risk category will automatically result in your actual risk changing? Okay, so what do they think is going on? When scientists try to explain why a larger body influences fertility and pregnancy, they can't just say it's the actual weight, because there's no impact of the actual weight on the internal organs or function in this case, their direct effect on reproductive cells or organs at the healthy versus unhealthy cutoffs that are based on BMI. Because the only defining feature of obesity is its definition. So to explain why weight impacts on fertility, they draw the bow that it's related to higher leptin levels paired with leptin resistance, higher insulin levels paired with insulin resistance, inflammation, and blood fats and their impact on reproductive hormones. All of these factors happen to smaller bodied people too, and they definitely do not happen in all larger bodied people, and all of them have things that can be done in terms of lifestyle and medication. The low-grade inflammation that's slightly more common in larger-bodied people has been linked to the chronic social stress arising from the experience of weight stigma. Usually cortisol arrives to respond to stressful situations and has an anti-inflammatory effect. But recent research has shown clearly that when cortisol is elevated for extended periods, the body becomes kind of cortisol resistant and it has less anti-inflammatory effect, leading to low-grade inflammation levels. High blood fats, particularly triglycerides, and when a person is not in energy balance and is gaining weight, have been found to change and impede the metabolic processes that occur during fertilization, leading sometimes to problems with development or implantation or growth, making early pregnancy loss more likely too if it does stick for a bit. High blood fats occur in people of all sizes, and there are dietary changes and medications that can help bring these down to within normal ranges without intentional weight loss, and that may have an impact on getting the pregnancy across the line. Leptin is a pro-inflammatory hormone that's involved in long-term energy balance and is produced primarily by fat cells. It's thought that its job is to regulate body weight in the long term by influencing appetite cues and modifying metabolic processes, bearing in mind that determining what its job is based on piecing together biochemical observations. So we definitely have a very incomplete understanding of this at the moment. Women tend to have higher leptin levels than men, regardless of weight, and people with more fat tissue tend to produce more leptin. Leptin, which is produced in fat cells, usually signals to the appetite centers in your brain that you're nourished, and so ramps down the strength of day-to-day appetite cues. The production of leptin can be decreased by starvation, impacting your appetite cues to tell you to please eat more, and increased by weight gain, because that increases the number of fat cells that are available to release leptin. It doesn't fluctuate so fast as to influence meal-to-meal hunger and satiety, but when there's not enough energy to go around, like if you're weight loss dieting, the body will produce less leptin, which brings on hunger to prompt more eating and slows down the metabolic rate to make the most of what is being eaten. But even if your body produces leptin in a regular fashion, sometimes cells can be less able to use it, and that's called leptin resistance, and it works in a similar fashion to insulin resistance. Like the orchestra is playing, but the audience is hard of hearing. So in this instance, there's a regular leptin pattern happening in the background, but leptin resistance will make that leptin less effective because it can't get to the appetite centres properly because the receptors are flaky, leading to the appetite centres to interpret the situation as one where there's insufficient food, so again ramps up the hunger signals. So it's the accessibility of leptin to the cells it's supposed to act upon that's key. And leptin resistance usually progresses with age, similarly to insulin resistance again. And leptin plays a role in the maturation of eggs in the ovaries and in stimulating trophoblastic stem cell growth, that's early in conception. And some have proposed that these reproductive elements don't respond to the leptin that is there because those cells are themselves less leptin sensitive. Leptin usually rises and falls during the menstrual cycle too. And leptin resistance means that your actual leptin levels can be low from not eating enough or normal to the degree that they would otherwise be involved in long-term weight regulation. But the body assumes they're low because the receptors don't work. All paths lead to increased appetite. As a result, it's thought that leptin is a key player in both the weight regain following intentional weight loss phenomenon in everyone and in weight creep due to leptin resistance. Essentially, these factors combine to make your appetite centre believe that you're not eating enough to sustain your body. Physical activity and resistance training without weight change can increase the numbers of leptin receptors, potentially making cells more sensitive to it again. But this process and the phenomenon is not well understood at this stage. It's an area of current furious research. Just in the last few years, they've identified a pretty blunt biochemical marker for leptin resistance. So there's loads of work to go yet. They've only just figured out how to detect it. And another compound secreted by fat tissue to watch in the literature is adiponectin in terms of fertility. So this is a watch this space kind of area. Most sources also offer the fact that polycystic ovarian syndrome, PCOS, occurs more frequently in people with high BMIs and cite this as a significant cause of irregular periods and thus subfertility. 12 to 18% of reproductive aged people with a uterus have PCOS, making it pretty common, but it's estimated that about 70% of them don't know that they have it. PCOS is considered the most common cause of anovulatory infertility, that's subfertility as a result of not ovulating frequently. And PCOS is a condition diagnosed on the basis of a constellation of hormone-related symptoms. And as an aside, if it's called a syndrome, it just means it's a condition that's diagnosed on the basis of a cluster of things rather than a single diagnostic marker. So people with PCOS have at least two of the following: irregular or non-existent periods, defined as either less than 21 days or more than 35 days apart, multiple not quite matured eggs in their ovaries, that's the cysts that the polycystic ovarian syndrome is named from, which have to be viewed using an ultrasound, or hyperandrogenism, which means high levels of hormones that influence male sexual characteristics. And this can be indicated by excessive hairiness or male pattern balding, or a blood test that detects raised free testosterone and or FAI, free androgen index. People with PCOS quite often find themselves gaining weight over time as part of the natural progression of the condition, and most of this is driven by insulin resistance, which basically means that the body finds it harder to use circulating energy sources as energy sources, leading to stored energy. Hello, fat tissue doing a great job of storing energy, and other tissues being, in a sense, starved because the energy sources can't get to them. It's the same process at play with early to mid-progression type 2 diabetes, and unsurprisingly, people with PCOS have a high chance of being diagnosed with type 2 diabetes as well. I also found a super new study that found that people with PCOS have higher leptin levels regardless of BMI, perhaps pointing to leptin resistance in PCOS also being part of the contributor to the weight gain phenomenon there. And what is the recommended treatment or management strategy for people with PCOS? Well, of course it's weight loss, isn't it? This is primarily because energy restriction has to occur for weight loss to occur, and insufficient energy intake temporarily makes the body more sensitive to insulin, which allows for more utilization of the energy in cells. It's an adaptation for periods of famine, which prompts a greater ability to make the most of the energy that is available. Being physically active also increases insulin sensitivity, as does a reduced carbohydrate load and various medications, including metformin, which is the most commonly prescribed prescription for both type 2 diabetes and PCOS. And think about the various things that people do to try to lose weight that are on that list. Eating less carbs, being more physically active, but it's a weight loss that gets the glory for making the difference yet again. Various studies have shown that for people with PCOS, small weight losses are associated with shorter time to pregnancy. While this looks like weight loss is doing the trick, the same problem exists as attributing the outcomes of weight loss studies to the weight loss itself, rather than the other factors that are impacted by the things you're doing to lose the weight. Just like with every other situation where high BMI is associated with this, that, and the other, losing weight to become not higher BMI'd anymore does not erase the proclivity to become heavier or the fact that you've been heavier. Both of those factors, the tendency to gain weight and a history of higher weight, are likely to be influenced by some other thing or things in the background that are also influencing the this, that, and the other that's being considered. So for people with PCOS, working with someone on factors to increase their insulin sensitivity, things like lifestyle or medication that may tip the balance towards more regular ovulation, and for some this may mean that coincidental weight loss occurs. And this is probably a good place also to point out that there are no superfoods for ovulation. All of that is bunk. Importantly, if you have lost weight prior to attempting to get pregnant, it doesn't look like it results in any increased pregnancy risk, as far as we can tell yet. The study found that in the year prior to pregnancy for people who were otherwise well, 4 or more kilos of weight loss was not associated with increased chance of pregnancy loss, even at a higher weight. But in that study, weight gain was associated with high risk of pregnancy loss, which makes sense in the light of the blood fats hypothesis I mentioned before. Rapid weight gain during pregnancy may also not be great for the baby, but it's not like people have much control over their weight changes during pregnancy, apart from significantly underfeeding themselves. I would think that someone who'd lost a significant amount of weight immediately prior to falling pregnant would be likely to experience the regular weight regain effect alongside pregnancy changes, and this of course may cause big alarm bells in their weight-focused care providers who may blame the person rather than see it in the context of weight restoration after dutifully following pre-pregnancy weight loss guidelines. And then pregnancy weight gain guidelines insinuate that weight gain should be controlled closely, while at the same time recommending against dieting. All of these pregnancy weight control guidelines are a trap and ignore that our bodies have evolved to be able to outwit our cognitions and adapt to our environment. Care providers who respond to weight changes in their clients during pregnancy as if they're simply a matter of behavioural control are dangerously mistaken. Weight loss during pregnancy is not a great idea, and here's why. Insufficient energy intake can restrict babies' growth, their organ development, and program them to be pre-adapted to a lifetime of famine conditions. The Barker hypothesis says that babies that had insufficient energy in the womb, i.e. their mothers were starving or losing weight, have variations in their genetics that predispose them to metabolic, endocrine, and physiological issues during their adult lives when there is enough energy to go around. This was first observed in people born to mothers who were pregnant with them during the Dutch famine in the 1940s and research on low birth weight babies. And we also know that babies in Japan have been being born with much fewer kidney filtration cells since the fashion for pregnancy bumps to be tiny has led many people to diet strictly through their pregnancies. Less dense and smaller kidneys leads to high blood pressure. And dieting during pregnancy is definitely not safe, and the smaller weight gain guidelines for larger mothers during pregnancy may well tip some of them into negative energy balance. And there have also been some rat studies that have shown that if the mother was energy restricted during pregnancy, that offspring went on to have earlier puberty, more concentrated fertility time, and earlier decline in their reproductive lifespan. It may indeed be that the early decline in fertility that some people are experiencing today is related to their mothers restricting food while they were pregnant. And what about the people who provide the sperm, who are so invisible in those government guidelines from before? Well, there is an association between high body weight and impaired spermatogenesis and sperm quality, particularly if diabetes is in the mix too. Age, alcohol consumption, over-exercising, and psychological stress have also been linked with issues. A BMI is related to lower sperm volume to the same magnitude as wearing boxers versus briefs relates to higher sperm volume. Leisure time physical activity looks like it supports sperm quality. In a well-designed weight loss study, semen volume was increased, but there was no improvement in sperm quality or motility. As an aside, imagine marketing your weight loss for men program on the basis of increased semen volume, which, now that I think of it, plays right into the hands of porn culture. Sigh. Anyway, this just means that it may take longer to have a successful conception, not that it won't happen at all. If time is of the essence for the eggs in the equation, and it most definitely is if from around your early 30s, it could make a big difference if the prospective parents could access reproductive services earlier. For egg quality, timing is everything and far eclipses the magnitude of the relationship between BMI and fertility. Larger-bodied kids also tend to start menstruating earlier, and their fertile years also tend to come to an end sooner, just like in that rat study from before. Even then, there is a huge variation in the age at which an individual's egg quality begins to decline. 50% of the people who experience persistent infertility will have become functionally infertile by the time they're 41. And for those who experience subfertility, the 50% mark is at age 31. For full menopause, the 50% mark occurs at 51 but begins at 41, with 10% experiencing menopause by the time they're 46. So if people have been trying to become pregnant for a year with no dice, what's next? Well, ideally, a prompt referral to a clinic offering assisted reproductive technology, or ART. Let's look at the guidelines around access to fertility services, and particularly access for larger-bodied people. It depends on where you live in the world, but most guidelines recommend that primary care clients be referred to assisted reproductive technology services if they've been trying to get pregnant for a year. If the maternal age is more than 35, sometimes this is reduced to 6 months of trying before a referral is possible. Generally, fertility services operate as for-fee services, with some reimbursements from health funds or limited access via nationalised health systems. In practice, this makes them commercial businesses rather than healthcare services. Because they might be in competition with one another, their pregnancy success rates are a marketing tool, the natural conclusion of which is that if they're selective with their clientele, their rate would be higher than that of services who accept everybody. So these centres essentially get to stipulate who they will and won't accept, and higher BMI is a favourite reason for refusal. The reasons they give for this vary from it'll mean you have a healthier lifestyle, nice assumptions there, to doing our things is harder if the body is larger, through to hand-wringing about miscarriage risk, assisted and traumatic birth risk like caesarean section and birth interventions, preterm birth risk, gestational diabetes, eventually fat offspring, chronic disease in risk of the offspring. The message is, we will find all the reasons why we don't have to try to help you, and even if we do, you'll hurt your child, so why even bother? These kinds of guidelines do seem to be dripping in healthism, suggesting that bringing someone into the world who has an increased risk of developing chronic disease at some point in their life is not worthy of being born is quite something, as is a suggestion that people perceived to have imperfect lifestyles are not deserving of fertility treatments or of children at all. This rears its head when it's suggested that larger-bodied kids be removed from their parents on the basis of assumed parental neglect, and on policies that restrict adoption on the basis of BMI. It's toxic perfectionism at play. If the stars aren't aligned perfectly, then we shouldn't proceed at all, when in reality there's never such thing as a perfect time or situation for falling pregnant. It's definitely tempered by cultural and individual factors, not just body function. We all have genetic quirks, and someone other than the owner of the genetic quirks making a judgment call about which quirks are worthy of passing on to the next generation is straight up paternalistic BS. And they're a fertility clinic, which means that they won't have anything to do with the birth itself or even the pregnancy once it's well established. So they're feigning concern for their obstetric and paediatric colleagues who will be helping larger people to and from birth with or without their contribution to their caseload. It's difficult not to read this as a veiled purity argument. I'm not the first to call out this kind of justification by a long shot, with Tremelin et al. Stating in 2017, it's hard to mount a convincing argument that a child is harmed more by conditions that materialise in middle age and are treatable compared with not being born at all. So what do they ask people to do before they can access their services then? Well, lose weight, of course, to some arbitrary BMI level that has precisely nothing to do with the individual circumstances of the people who want to get pregnant. It's clear from their public-facing materials that they believe that larger-bodied people are that way because of their lifestyles, and that a lifestyle change will be enough to lose weight in order to access their treatments. That understanding is basically the only ethical way they might be able to get away with this, but of course we know that it falls over as soon as you look at the research. The types of things that fertility clinics can do to improve the chances of a pregnancy include flushing the fallopian tubes, ovulation induction, artificial insemination, and finally IVF. The fact that you're having difficulty falling pregnant in no way means that you're not meant to become pregnant, and being able to fall pregnant without assistance is not a screening test for whether the baby's going to be healthy. If that were the case, then there would be some hand-wringing for everyone who accesses fertility services. You can't argue that someone who has had trouble getting pregnant because their tubes were blocked and falls pregnant as soon as they're flushed should have been denied fertility services on the basis of their weight. To deny them the opportunity to have their subfertility investigated in the first place is abhorrent. For a person with what are considered poor quality eggs, losing weight is going to do precisely 0 things to their eggs, except make sure that they're even more degraded by the time a pregnancy is attempted. This is the tyranny and risk of using population stats to drive individual decision making. And although it makes intuitive sense to want to jump into a lower risk category where fewer people have poor quality eggs on average, it's utterly unscientific. It in no way means that your eggs will turn back the clock with weight loss. We have to remember that those eggs have been there since that person was a fetus in their mother's tummy. They're humanity's doomsday crypts of human information. Some of the processes used in IVF, where the fertilization and initial embryo growth happen outside of the body, can restore or improve some of the factors that are impacted by egg age, but you've got to have access to that service before you know if it's going to help you. The only areas where increased insulin sensitivity, lower blood triglycerides, and possibly increased leptin sensitivity may help is in the maturation of the egg in the ovary, in the early development of the embryo, and in the implantation into the uterine lining. And that's because it's hormones that do a lot of the signalling for these processes to proceed. An energy restriction can increase those factors in some people, as I mentioned earlier, but so can being physically active and some dietary factors. But only if your body has those particular issues, and you won't know unless you get blood tests. Being physically active and eating well are usually pretty good for you in general, so I'm not saying not to do those things. The only thing that I would definitely recommend is a prenatal vitamin that includes at least folate. But back to the question, does weight loss before accessing assisted reproductive services actually make a difference? Well, it gives you more time to fall pregnant naturally, but if the problem is an obstructed tube or sperm motility or rapidly aging eggs, or if you're accessing ART because you wish to begin a family by yourself and you're using a donor, there is 0 point to delaying seeing them. Considering how widespread the advice to lose weight before attempting pregnancy or accessing ART, there is surprisingly few studies that have investigated this. Not until a few years ago were there well-designed randomized control trials examining intentional weight loss for larger-bodied people before accessing IVF versus accessing IVF services immediately. Gaskins has summarised this nicely, so I'm going to read from their paper, Recent Advances in Understanding the Relationship Between Long and Short-Term Weight Change and Fertility, from 2018, and this is in the supplementary materials too. The lifestyle trial was a large Dutch RCT that included 577 women randomly assigned to either a 6-month lifestyle intervention prior to 18 months of infertility treatment or prompt infertility treatment for 24 months. This seminal study found no differences in the proportion of women achieving a clinical pregnancy or live birth between the groups 2 years after randomization. In fact, women in the control group had a significantly shorter median time to pregnancy, resulting in live birth, 5.2 months, compared with the intervention group, 8.8 months, likely because the former proceeded directly to infertility treatment. The only findings in support of weight loss were that women in the intervention group had more ongoing pregnancies that resulted from natural conceptions, and the number of infertility treatment cycles was lower in the intervention group compared with the control. The benefit of weight loss on natural conceptions was also shown in a follow-up article to be driven specifically by anovulatory obese women at baseline, as the effect was much less pronounced among ovulatory women. Although the findings of this influential RCT were mostly seen as discouraging, less than a year later, another large RCT of weight loss prior to IVF treatment among obese women was published with similar results. Though not as large as the original Dutch study, this randomized control trial was the second largest, including 317 obese infertile women from Sweden, Denmark, and Iceland who were randomly assigned to an intervention consisting of 12 weeks of a low-calorie liquid diet, followed by 2 to 5 weeks of weight stabilization or a control group with IVF only. Both groups of women were followed through the completion of one IVF cycle. By the end of follow-up, although women in the intervention group had more spontaneous pregnancies leading to live birth than the control group, there were no significant differences in the proportion of women achieving clinical pregnancy or live birth across the two groups. Prior to these trials, most scientists and clinicians believed that short-term weight loss would improve reproductive outcomes in obese women with infertility. The counterintuitive results from these two large, well-conducted RCTs, however, pretty conclusively showed that short-term weight loss for obese infertile women does not remedy the outcomes of IVF cycles. The RCTs also nicely highlight the importance of high-quality randomised trials, particularly in settings where common sense suggests that the answer is already known. An additional large multi-site randomised control trial investigating a similar question is ongoing in the US. However, until its results are published, the best evidence remains that short-term weight loss does not appear beneficial for most infertile obese women undergoing infertility treatment. End quote. That paper is also great at highlighting the huge gaps in experimental research about weight change and fertility. It's still weight-centric overall, but it's a good summary and it's open access. It's important to remember that these stats about the factors associated with pregnancy at a higher weight are overwhelmingly derived from studies of larger-bodied people seeking assistance with becoming pregnant. So they're critically confounded by this fact. It's the same problem we have when we make generalizations about all larger-bodied people based on the characteristics of people who are seeking weight loss services. For example, that they're more depressed than the average smaller-bodied person, etc. Even studies about low-grade inflammation in larger-bodied people are based on these kinds of people. And we know that inflammation is also associated with internalized weight stigma. What we need is a representative sample of larger people who are not trying to change their weight and who appreciate their bodies primarily for their function and services to existence, not their appearance characteristics. So people with larger bodies who want to become pregnant try to do so in the traditional way and are more often than not successful in that aim. When they encounter difficulties, many may avoid speaking to their primary care provider about it due to the belief that they may be turned away for assisted reproductive services due to their weight, and they avoid that conversation because people are hardwired to prefer avoiding humiliation and shame. So certainly their presentation at the GP may be delayed, and that delay in itself may be critical to becoming pregnant thanks to the egg's doomsday clock. Undiagnosed and unmanaged PCOS leads to even more delay. The ones turning up at assisted reproductive technology services are the most desperate ones, the ones willing to receive a potentially humiliating experience for the chance to have a pregnancy. But it shouldn't be this way. BMI should be no barrier to accessing fertility assistance. The conditions that impact on a larger-bodied person's likelihood of becoming pregnant occur in smaller-bodied people, and many larger-bodied people do not have the hormonal and metabolic issues that are theorised to influence fertility for people with high BMIs. If people with PCOS or type 2 diabetes can access services at a lower weight, there is no reason for people with high BMIs to deny access, as the justifications for denial of service using hormonal and metabolic circumstances are no different from in these conditions at any weight. There are so many factors that cannot be accounted for that influence fertility that there is no argument that can be made that weight itself is a significant part of it for an individual, and certainly without extensive investigations. And yet here we are, with some fertility centres refusing to offer even an initial appointment for people with high BMIs. The only way that I can see this changing is via anti-discrimination lawsuits. This could be made easier on the basis of PCOS not being such a stigmatised condition. And if smaller-bodied people with PCOS can access services, then there's no way of being able to determine if a larger-bodied person with PCOS is experiencing subfertility because of the PCOS or their body weight, or if the PCOS is the reason their weight has increased. So they might be able to make a case for it to be being discriminatory, and that may help increase access to ART for everyone with PCOS and or a higher body weight. The question that really sets up the ethical, legal and political lines of argument is whether or not subfertility itself is considered a medical condition. Basically, is pursuing a pregnancy a choice or a right? Those denying access to fertility services on the basis of BMI would say that it's a choice, and it's a choice that the person has made by recklessly having or continuing to have a larger body. My position is that any healthcare system factors that block options to investigate the causes of subfertility or block the ability for an adult to pursue pregnancy after being provided with clear and comprehensive risks, benefits and probability information is a human rights violation. It's heartening to see that this sentiment is appearing in multiple places in academic literature. Now it's time to lean on our fertility and healthcare providers and organisations that represent their interests to let them know loud and clear that this discrimination cannot continue. So, that's it for this episode. I'm glad my voice made it. Hopefully I'll be recovered by next time. The supporting materials, which include the show notes, research links and self-test quiz, are available up front for current subscribers, only $5 a month, bargain, or can be purchased in a bundle if you're catching up later. See unpackingweightscience.com for details. And next time, episode 26 is going to be a summary of my PhD research. I'm just about to finish writing my thesis about the suitability of approaches that endorse health-focused size acceptance, like health at every size and intuitive eating, in one-on-one nutrition and dietetics counselling. So while it's all fresh in my head, I'm going to give you a wrap-up of what I wanted to find out, how I went about it, and what I found. So until next time, goodbye.